A neurology consultation is requested for a 56-year-old man who is exhibiting abnormal jerking movements. 2 weeks ago, while in the hospital for pneumonia, he went into the sudden cardiorespiratory arrest. Resuscitation efforts in the hospital were successful after 7 minutes. He regained consciousness within 2 days of the arrest. On examination, he is being ventilated through a tracheostomy and is not on any medications. He is able to open his eyes and raise both arms on command and show two fingers or a thumbs up sign. He demonstrates uncontrollable jerking movement in his limbs and trunks whenever a movement is initiated. Basic metabolic panel and liver functions are normal. Which of the following is the most likely diagnosis? Let us consider one after another. Start from the second one, the May-White syndrome. This is a rare familial progressive myoclonic epilepsy with lipomas, deafness, and ataxia. This syndrome is probably a familial form of mitochondrial encephalopathy, so does not fit into the likely diagnosis. The next one is the whether this disease is the metabolic myoclonus. As the metabolic parameters are normal, so it is again unlikely. The fourth one, the myoclonic seizures. Coming to the myoclonic, few words about the metabolic myoclonus. It is due to the metabolic disturbances. It may be multifocal, asymmetric, and stimulus induced. It usually involves facial or the proximal limb muscles. If the disturbance persists, generalized myoclonic jerks and ultimately seizures may occur. Now, myoclonic seizures are a type of seizures that causes a quick, uncontrollable muscle movement with no change in your level of awareness or consciousness. These usually affect either one muscle or a group of related muscles, but can sometimes affect wider areas of your body. Seems to be that the history does not fit into this also in total, though it may be a part of the myoclonic seizures. Let's come to the Lanes-Adams syndrome. This is a rare condition in which the post-hypoxic myoclonus occurs days to weeks after successful cardiopulmonary resuscitation. Myoclonus in LAS is typically triggered by the intentional actions or external stimuli, is relieved during sleep or rest, and has no reliable correlate with the EEG. Pathophysiology is poorly understood. Probably it is a subcortical or cortical. It is important to differentiate from the acute post-hypoxic seizures in which patients remain in a comatose or vegetative states. This often can result in a significant morbidity. Now, although it is a non-epileptic syndrome, still the anti-epileptic medications may help. So, coming back to the history, it seems to fit into the likely diagnosis of the Lanes-Adams syndrome. Thanks.